Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Richard Jiang. Is that the correct pronunciation?
You got it, Mary.
And you are a PharmD and you're a pharmacist, and you're currently working at Peninsula Regional Medical Center in an internship residency program. And you were nice enough to volunteer to come on the show to talk about a very important group of medications, the statin drugs that we use to lower cholesterol and in turn address cardiovascular disease. So before you get started enlightening us about this very important class of medications, I just wanted to bring up a number I found online about the prevalence of their use. And I found that in a published study from 2016, it's estimated that 38.6 Americans are on a statin. That's a lot of people.
Absolutely.
So let's assume these drugs work well. They do what they're supposed to do because they're used quite a bit. So tell us more about statins and why exactly they're used, and then we'll get into which ones, are the most common and side effects and so forth.
Sure. So statins are a group of drugs that lower cholesterol, obviously, and the way it works is it blocks something we call HMG-CoA reductase, and by doing that, it stops cholesterol synthesis. And the way statins do that, by blocking the cholesterol synthesis, ultimately what it ends up to is by decreasing LDL, which is what we call our bad cholesterol, and then it can also increase slightly your good HDL, which is our good cholesterol. And also some statins also have the ability to decrease your triglycerides as well. So statins are typically used for, the way we think of it commonly is we try to decrease cholesterol with the statins, but ultimately what we want to do with statins is to decrease cholesterol, which will eventually lead to decreased cardiovascular disease such as heart attacks and strokes.
So are there any particular food interactions with statin drugs?
Yeah, so there's one potential. It's with grapefruit juice, and that's probably what you might see labeled on the bottle of your statin when you get it back from the pharmacy. So let's say avoid grapefruit juice. So there's definitely an interaction there with the grapefruit juice, and one of the ingredients inside the grapefruit itself can decrease the metabolism of the statin, so make it stay in your system a little bit longer, so you get the effects from the statin for a longer period of time. Now that really only occurs, and really you'll start seeing side effects from that if you drink large amounts of grapefruit juice. So if it's just, a casual glass of grapefruit juice once a day or even once a week, I don't think that's a big problem at all. It's when you start hitting the volumes of 1 liter, 2 liters, then that can be...
That's a lot of grapefruit juice.
Exactly. And I don't think there's people there that drink that much, but if you do, then and you're on a statin, I would probably cut back on that grapefruit juice if that's the case.
Well, just in general, grapefruit juice interacts with many different medications.
So statins are
they
just
say older adults generally, if they're on a lot of different medications, should just kind of stay away from grapefruit juice or double check with their doctor if they do like it. Some people don't even like it, but people that do like it, they'd have to give it up. So let's go back to the lab components you were mentioning earlier. There's a number a person will get as part of their lipid profile. That is the cholesterol level, total cholesterol. And then we have the good cholesterol, which is the HDL. And then we have what we call the bad cholesterol that you want to keep low, which is the LDL, and then the triglycerides. So do these statins as a group of drugs address all 4 of those components?
Yeah, so in essence, most statins will have the ability to address all 3, which is your LDL, HDL, and also your triglycerides, which ultimately add to your total cholesterol. So depending on which statin you use, they will address it differently. And depending on what type, your intensity of your statin, so whether it's a low intensity, moderate intensity, or your high intensity, the decrease in your LDL, increase in HDL, and decrease in triglycerides are a little bit dependent on that. But generally speaking, when we're using statins, we're targeting the LDL, not so much the triglycerides or the HDL.
So what would be the 4 groups of people that benefit from the use of these statin drugs?
So the 4 groups that we typically start statins on are going to be: 1, patients that have a history of some sort of cardiovascular disease, such as a heart attack or a stroke, patients that have an LDL greater than 190, patients that have a history of diabetes, and also patients that have a risk score that we can assess, doctors can assess for the patient greater than X%. And those patients, usually we look for greater than 7.5% risk for some sort of coronary event in a 10-year period. Those patients would be the last group that would require a statin to be started.
And those risks, that risk factor percentage is from that Framingham study that came up with that?
Yes, exactly. And some of the things that go into it is going to be age, patients that have high blood pressure, those that are smoking, again, diabetics, and these are very big components that factor into people with a higher risk for a sort of a cardiovascular event.
Okay, and of course we know about diabetes, and that just seems to be an automatic thing. Is there a particular age for any of this? I mean, other than having an event already where the doctor says, okay, you've had a heart attack or you've had a stroke, so we need to start on a statin.
So generally we focus on our older population, our more senior populations that will have things such as this, but this is not going to be isolated just to one age group. So obviously once you get older, you're going to be at higher risk. But generally, as soon as you start taking, you get your yearly physical, and then you can assess your risk factors. Are you a smoker? Do you have high blood pressure? Even at the age of 30, somebody might be started on a statin based on certain risk factors and if they meet that criteria.
So in addition to age, even though it's not necessarily the factor, there can be a genetic predisposition, can there, to either having a cardiac event. You hear about men that have heart attacks earlier on, usually their father or some first-degree relative has had that issue, or some people may just have that predisposition to having a higher cholesterol, and it really has nothing to do with how much cholesterol you eat. It's a matter of your body not breaking it down, correct?
Absolutely. So for high cholesterol, there's absolutely a genetic component that's involved. So just because you can have great diet, you exercise all the time, you're slim, you have a great BMI, but with all those things in consideration, you can still have elevated cholesterol, and that's because of that genetic component. So they do go hand in hand in terms of how it affects people.
So what would be some of the examples of these statin drugs? And of course, if you wouldn't mind giving the brand name and the generic name, because we're moving more towards knowing drugs by the generic name, because there's so many brand names now. And then also that whole intensity thing you alluded to earlier, some are low intensity versus high intensity.
So the ones that are most popular, I would definitely say number 1 is probably Lipitor, which is better known as atorvastatin. We have a older drug, which is Zocor, which is simvastatin, and then a more recent one, which is also generic now that we use quite often, is Crestor, which is rosuvastatin.
Was Zocor the first one?
Zocor was not the first one. One of the first ones, I believe it was fluvastatin and lovastatin. Correct me if I'm wrong. I don't have, statins go back so long.
Right.
I might have missed some of the history back there.
But these 3 that you just mentioned, Lipitor, Crestor, and Zocor.
Yeah, those are probably the ones that we use more times than not these days. And going back to answer your other question about the intensities, typically we call our high-intensity statins a strength of a statin. So for example, Lipitor 40 milligrams and up can decrease your LDL by around 40 to 60%. So once we hit that target and have the ability to decrease your LDL by that much, we usually start calling the statins a high-intensity statin. So for example, Crestor 20 milligrams would be considered a high-intensity statin.
Oh, okay. So it's more about the dosing of it and achieving that reduction.
Exactly.
That's quite a significant reduction.
It is. And one thing to keep in mind is because you double your statin dose, it doesn't mean that you'll double your LDL decrease. So if I give you 40 milligrams of, say, Lipitor, and I can decrease your LDL by 50%, but you find out that in your next yearly physical that you're still not at goal, by increasing your Lipitor to 80 milligrams a day won't decrease another 50%.
Right.
Rather, what you'll see is actually a decrease about 5 to 10%, if that.
So you're definitely seeing your healthcare provider more frequently earlier on to get your levels drawn and to find out what the optimum dose is to bring you down to a good level.
Correct. So probably, you know, every other month initially, and then once you're stable, you'll start taking, just dependent on yearly physicals, and even longer, depending on what your doctor thinks is appropriate.
Okay. Now I know there's a medication called Zetia, and you hear about that being used for cholesterol, and it works a little differently, but you're saying that's not a statin.
No.
But tell us a little bit about Zetia and how it might be used with a statin.
So typically, statins, they do have this adverse effect that some people may not be able to tolerate, which is what we know as myalgia, which is muscle pain, muscle aches, and that's one of these, it's a very small side effect that we rarely see, but sometimes it does occur with the use of statins. So Zetia, usually what will you do is, if you can't tolerate that high intensity statin to decrease your LDL goal, what we'll do is we'll add on something like a Zetia, and you can use it in combination with a statin to bring down your LDL by 10-15% more.
And obviously that's not a statin, it works a little differently.
Right.
And remind us again, without getting too technical, how the statins actually work to bring the cholesterol down and in turn reduce your risk of cardiovascular events.
So the way statins work is based on its mechanism of action. It inhibits what we call HMG-CoA reductase, which is a key step in cholesterol synthesis. So statins go in and they block cholesterol synthesis through that pathway. By doing so, we decrease the amount of cholesterol that's being made and the amount of cholesterol that's circulating in the blood. And we know that these cardiovascular events occur because when we have more fat, more cholesterol flowing in the blood, this leads to the buildup of plaque. The plaque ends up hardening, and then eventually what happens is you have this hardened plaque that can occlude arteries and decrease oxygenation to the heart, the brain, leading to things like heart attack, stroke.
Okay, thank you. Now, you mentioned myalgia or muscle aches can be one of the more problematic side effects. And also, doesn't it affect the liver?
Absolutely. So another side effect that you might see with statins is increase in your LFTs, so your liver function
test.
Exactly. So the enzymes that we'll see when we look at your liver function. So generally speaking, if you see a high elevation in that, there means there's something wrong. The statin is negatively affecting your liver. So your doctor might say, hey, let's hold off on it for a little bit and let's try go a different route in terms of using the statin.
So elevated liver enzymes are not good and a side effect potentially of some statins or all of them. But the other thing is, aren't all these drugs generic now? They've been around a while, so you can get them at a more reasonable price through your pharmacist?
Because they are generic nowadays, it is easier for your insurance to actually cover it, and you end up with lower copay versus getting that brand drug, which typically you'll have the higher tier and you end up with a higher copay. So your Lipitor, Crestor, and Simvastatin, they've both been out in the market for such a long time now. They became generic, and now you can get them at a much cheaper, more affordable copay or cost.
Right, that's good news. The other thing is, I know there's been some recent research about how long you need to stay on statins once you reach a certain age.
Sure.
So when does it become where some of the risk of being on a statin once you reach a certain age, you know, outweigh the benefits, or that you talked about the risk of having a cardiovascular event in 10 years. So explain that balance there.
Yeah, so I would say once you reach that threshold of, you know, around 75 to 85, that age group, if you are adding on a statin, definitely is something I would probably, some things I would take into consideration is even, should you add the statin on? The dose of the statin, whether you need a high intensity statin or a moderate intensity statin, because as you age, you are more susceptible to certain side effects, such as your myalgias, such as elevations in your liver enzymes. So those are certain things that I would consider whether or not I want to initiate. Would I consider taking somebody off of it? That's a different story. If somebody's tolerating it and they're at a high age, like the 75, 85 threshold that I mentioned, I might not, if they're tolerating it, I might not consider pulling back on it. But starting it on somebody of that age, that's something I would take into consideration, because I don't want the person to deal with those side effects polypharmacy, adding on extra drug interactions, and those are all things that I would take into consideration and make a recommendation to the patient and the physician.
I guess we'll be seeing more studies on that too, of when it might be a good idea to consider taking the statin out of the mix, because older adults these days are now on so many different medications.
Exactly.
And sometimes there can be interactions and problems. Now, with all these kind of drugs that are affecting heart disease and so forth, the drug is not the magic bullet. I mean, it's very helpful.
Right.
And particularly if you have that predisposition and so forth to having a high cholesterol level and so forth, but at the same time, you do have to exercise common sense and the lifestyle changes and diet,
absolutely.
exercise, stop smoking. Isn't that a very important?
Absolutely. So smoking is definitely a big risk factor into that Framingham risk score that we talked about earlier. So smoking does play a big role. High cholesterol level definitely plays a big role, and also hypertension. So some of the things that we can do is stop smoking, have a better diet, such as a diet that's low in sodium, diet that's low in fats, and try to focus on certain things like our carbs and proteins, so and high in vegetables as well.
And now when you say low in fats, that doesn't necessarily mean they have to go on a cholesterol-free diet.
Exactly.
Because we do need cholesterol for brain function and so forth. And I know the big revelation some time ago was it's not really about the cholesterol that you eat. It's more about how you process it.
Sure.
So the fats, however, getting away from saturated fats.
Exactly. So the fried foods, potato chips, burgers, things like that, probably not have too much of. Everything in moderation. Don't overdo it, and instead focus on other fats such as your better fats that come from things such as your peanuts, fish, things like that.
Right, I know. Years ago, we stayed away from avocados and eggs and nuts, and now we're finding they have good fat that we should eat, but everything in moderation. You're right on that. So let's just talk about, to wrap up, some of the key points you want our viewers to remember about statins, or important questions they might want to keep in the back of their mind if they want to talk to their doctor about it.
Sure. So definitely if you fit one of those benefit groups that we mentioned earlier, so if you had such an event like a stroke or a heart attack in the past, if you are a diabetic, if you smoke, have high blood pressure, you have a high LDL, so those certain risk factors, then you probably should be considering starting a statin. If you are on a statin, you should definitely talk to your pharmacist, talk to your doctor, review your drugs, other drugs that you're on, to see if there are certain drug interactions, and you should also be cognizant of certain risk factors for drug side effects from the statins, such as muscle aches, muscle pain, tiredness, soreness, things like that. That might be a sign of something like myalgia that might be coming from a statin.
Of course, your physician will help, or your healthcare provider will be monitoring your liver enzymes.
Yes, and assessing that risk factor, where you fall in terms of, do you really need a statin or not? So that's your doctor's responsibility to make sure that you are on a statin for correct reason, correct indication. And then your pharmacist obviously would be the one making sure that there aren't other drugs that might be playing a potential interaction with your statin, causing certain side effects to be more prone or more common to occur.
Well, I like how you talk to your pharmacist. It's important to ask questions, especially when you're picking up your medication. There's an opportunity to talk to your pharmacist on the side and ask questions like that, or of course ask your healthcare provider questions.
Pharmacists are a free resource.
Exactly.
The only thing you pay for is the drug, and when you bump into your pharmacist at the pharmacy, it's the best time to ask them, because they're always readily available.
Well, certainly some wonderful information on a very commonly prescribed group of medications that are important. They work. I mean, a lot of people are on them because they do the job, and it's one of the bigger, I think, developments, in terms of medications in the past few decades. So we appreciate very much you coming in and talking to us, and we'll post some websites that you brought for our viewers to get more information. So thanks again.
Thank you. Pleasure was mine. Thanks, Mary.
And thank you for joining us for this edition of Focus on Health here on PAC 14.